All right, guys, in this video, this is the second one, and this is mostly about the behavioral sciences and the medications and really the drugs. And so, again, you want to learn how to go from a diagnosis to a treatment to a medication and vice versa, kind of like back and forth throughout that. Now, if you find any questions that are difficult, please send them in, and we'll use them and put them out there for you. All right, guys, it says, if toxicology tests are positive, which of the following substances is most likely detected? You look through these, and it looks like there's a bunch of drugs here. So, 25-year-old man is brought to the emergency department by police. He was detained at his apartment because of aggressive behavior toward his girlfriend. The patient appears agitated, disoriented, and confused. Vertical nystagmus and ataxia are present on neurological examination. Okay? So, whenever you see step one, aggressive behavior and or vertical nystagmus, you got to be jumping all over PCP, period, right? Because, I mean, marijuana, you're not going to get someone that's going to be typically agitated unless the guy got some synthetic stuff that got a little something else in there. Heroin, it's an opioid, it's going to depress you, it's going to get you bring down. It's not really going to agitate somebody. Now, these are, stimulants, and they can give you the psychosis, per se, if you take too much, but they wouldn't really explain the vertical nystagmus, which is kind of pathognomonic for PCP. Diazepam is a benzodiazepine. It's going to make you more sedated, and LSD more of a hallucinogen, and they didn't really talk about that. So whenever you see this, you better be jumping all over PCP. Very popular kind of question. This one says, the drug is most likely to be which of the following? All right, so we look through those. 79-year-old man has had urinary retention, okay, for the past week. He's been treated for the past 2 weeks with a drug for chronic neuropathic pain. All right, so they're just testing your knowledge of what would you give somebody for chronic neuropathic pain, and apparently this thing has urinary retention, which is an anti-cholinergic kind of response, right? Urinary retention, dilated pupils, all that kind of good stuff. So, which of these is anticholinergic and treats chronic pain? We look through these answer choices, and the only one that I see is going to be the amitriptyline, which is a TCA. With that, Wellbutrin, right? Bupropion. What do we worry about Wellbutrin? It decreases seizure threshold, right? That's kind of the one that you want to kind of keep in the back pocket when you think about Wellbutrin. Fluoxetine, also known as Prozac, I want you to know that. It's been around forever, well studied, good medication. It's a big 2D6 kind of goes in that pathway, so that affects a lot of stuff. Ironically, kind of in real practice, be careful when people are on, like, say, Adderall or some type of stimulant, because they're processed, these are metabolized down a pathway that fluoxetine inhibits. So a lot of times if someone's on Prozac and they start taking Adderall, they can increase and lead to a bad outcome. Anyways, venlafaxine, also known as Effexor, another kind of a 2D6 pathway type of guy. The one that you want to know about this guy is the withdrawal. This guy has like withdrawal side effects, right? If they miss a dose or they stop it abruptly, this is the one where you get that, they call it like lightning bolt sensations. I've seen that question before. Carbamazepine. What you better know about this guy is what? It's one of the inducers, okay? You better, with 100% certainty, know the difference between the inducers and the inhibitors, the medications, okay? And that's what this is about. Remember that there's like a mnemonic everyone's got different ones, but the ones I remember is that Queen, Barb, steals fen-phen, and eats greasy carbs continuously, like quinidine, barbiturate, St. John's wort, phenytoin, griseofulvin, carbamazepine, and then chronic alcohol use. And then remember the ones that are the inhibitors are the magic racks. And you don't need me to recite those, but you better know these. I'm telling you, step 1, step 2, step 3, hit this till the cows come home. You got to know these, because this is going to be a lot of your answer choices with this. But carbamazepine would be more of an inducer, and then Zoloft is just an SSRI, selective serotonin reuptake inhibitor, not what they're talking about here. The best answer choice, the only answer choice in this one, is going to be the TCA, amitriptyline. Okay, this one. Whenever you see these questions that are with the quotes, I want you to think like this. They're asking you what's the most appropriate response. You need to approach these as though you are sitting with the residency director. Okay, and how would your response be if you're sitting with them? It's going to be the most polite, the most politically correct, the most neutral response that you can, acknowledge people's feelings and still get what you need. So this one says, 37-year-old man comes to the physician because of a 3-day history of burning with urination. He states that during a recent trip he had an affair. The next day, the patient's wife calls the physician and asks, "My husband has a new prescription. Does he have a sexually transmitted disease? Which of the following responses by the physician is most appropriate? Is it A, I recommend that you see your physician as soon as possible? Is it B, I would ask your husband, if he has had any extramarital affairs recently? C, no worries, the medication will do its job. D, I'm sorry, but I will need your husband's permission to discuss his care with you. Or E, I recommend you seek counsel for divorce." Obviously, the most neutral, the most appropriate, if you're going to not violate HIPAA, is going to be, "I'm sorry, but we'll need your husband's permission." Despite them being married, you got to have the release, okay? You got to have that HIPAA release. But again, approach these as though you're sitting with the residency director during the interview process, and you will automatically default, maybe not to sometimes how you feel, but default to what's the most appropriate response. This one says, you select which of the following. They're looking at the medications here. It looks like they got a benzo. They're all benzos. So, 31-year-old woman presents with generalized anxiety disorder and recurrent panic attacks. You initiate therapy with paroxetine, also known as Paxil, but the patient requests medications to help immediately. If she starts to have symptoms, you elect to use a benzodiazepine that has the shortest half-life. So this is just more of a memory thing. Okay, this is just more of, do you know which one has the shortest half-life? Well, even if you didn't, chlordiazepine epoxide, also known as Librium, that's the one they use for alcohol withdrawal. So that one's a pretty long one. Same thing with clonazepam. Usually when you transition people off benzos, clonazepam is one you can use because it's very long. And just so you know, these two guys are more mid range. The shortest one, and again, this isn't really a teaching point other than a memorization. It's just going to be the alprazolam, also known as Xanax. Now, the one thing you do need to know for the steps is they might ask you, is the benzos that aren't metabolized per se in the liver, and that's going to be set is the OTL, right, outside the liver, and so that's going to be your oxazepam. That's going to be your temazepam, and of course your lorazepam. Okay, these are metabolized outside the liver, so sometimes they like these for your alcohol people if they have kind of hepatic insufficiency, from the prolonged alcohol use. But for this question, this answer, the shortest one, it's going to be your alprazolam. Which of the following is most likely direct mechanism of the beneficial effect of the drug? So again, they're saying the patient takes a TCA. So what's the mechanism of the TCA? Is it inhibition of adenosine, monoamoxamine, norepinephrine, adenosine, dopaminergic? Well, it's not dopaminergic, right? Those are antipsychotics, not adenosine. It's going to be TCA, strict memorization. It's going to be the norepinephrine, okay? Be careful when because they could have norepinephrine in two answer choices, and they could either say inhibition or stimulation of the norepinephrine. So don't just memorize that it's norepinephrine. Understand that there's a difference between, obviously, inhibition, like antagonist, versus an agonist of that one as well. Okay. This one says, sudden withdrawal from which of the following substances is most likely to produce life-threatening issues. And again, this isn't really a teaching. This is strictly memorization. But if you didn't know how to handle this question, you can tell that this answer choice is a stimulant, and a stimulant. So those are all relatively the same option, but it appears that you have heroin, which is an opioid, okay, and then you have this barbiturate, okay. In between those two, you're going to know that it's the barbiturate, and you have to watch out for, they would have to give you something with this in here. I don't think, obviously they can't use certain terms like Percocet or anything like that has that. So look for the barbiturate. The barbiturate's the one that has life-threatening withdrawal. So if someone is on Percocet and they come in, just be aware. A little extra look for them. Which of the following is the most likely diagnosis? Now, we kind of touched this on a different video, but it says a 37-year-old woman has a 12-year history of chest pain, back pain, vomiting, abdominal pain, difficulty urinating, fainting spells, numbness and tingling. Oh my God, she's got everything in the book. You know, you kind of cringe when you see this come in the door. So she's got multiple systems, not just one, right? Because if it's conversion, what do we say? We look on that one, it's the neurologic, right? It's got to be neurologic, mostly the CNS, where there is some voluntary control over the part of it's under voluntary control, but it's neurologic only. This one has more than just neurologic. Somatization, that's the one that's going to be the multiple system. So I'm liking that one right now. Hypochondriasis, that's the one to where you're more fixated on the diagnosis or the disease rather than the symptoms. Major depression, that's going to be our SIGE CAPS, right? Obsessive compulsive, meaning you have this kind of, it's like a recurrent intrusive thought, and then you might have a little bit of reduction when you do this extra kind of behavior, the compulsion, wringing your hands or, opening the doors and stuff like that. That's not what this person has. Illness, anxiety. Remember, I kind of touched on this on that last one, the mood disorder video, is illness, anxiety says, hey, look, do you have any symptoms? No. Do you have disease? No. But I'm worried about catching it. That's illness, anxiety. They don't have any confirmation of anything, but they're worried about getting it. It's kind of like going out in public and you're worried about catching a specific disease. And then this mood disorder secondary to medical condition, I should have said it's more of a, that one where it's, name escapes me, but you're more worried about, you have the disease, you already have the condition, you're just worried about how that's going to affect you. It's like psychological factors affecting medical condition. So in this one, the only answer, since it's multiple systems, you're going to say it's the somatization. Okay? This one, I see this, when I scan this, I see this thing GGT. When I think GGT, I think alcohol. But I look at the answer choices and it's all these questions, okay? So again, you're sitting with your residency director during the interview, how are you going to answer it? 60-year-old man comes to the physician because he's had malaise, fatigue, and anorexia since losing his job 3 months ago. Serum GGT activity is increased. Now, which of the following questions is most appropriate to initiate discussion? So the GGT is increased. So do you think this guy drinks? Yes. Okay. So are you going to say, hey, do you think you were a problem drinker? Is it B, how much do you drink in a typical week? Is it C, is there something you have not told me so far? Or, so do you think you hit the bottle sometimes? Is it E, what is your favorite drink? And F, you're not a drinker, are you? Now, again, you don't want to act rude to the guy. You don't want to shut down the whole kind of getting that rapport with them, so you're not going to say something sarcastic. But if you already know that someone's kind of a drinker, you can just go in and say, hey, how much do you drink in a typical week? Because it's kind of establishing, you know the drink, and it just gets right to the point. Because if you ask them, hey, do you drink? They might say no, they might minimize. But if you go straight to it, they're probably going to say exactly how much and, how often. Do you drink in the morning? All that kind of good stuff. So, again, residency director, this is going to be the one you're going to ask. Intoxication in which of the following substances is most likely? Okay, LSD, tetrahydrocannabinol, heroin, PCP, Valium. So in this one, it says after emerging from a smoke in the men's room at a bar, a 26-year-old male becomes agitated and belligerent. Okay, now what do we say? Someone becomes agitated and belligerent. What are you going to jump on? PCP. Okay, hands down. Period. Just do it. All right. He displays intermittent clinic jerking of his extremities and assaults a bouncer. So this guy's violent. Got to be jumping all over PCP. LSD, hallucinogen. With the cannabinoid, you're just not going to get there unless it's filled with synthetic or something. Heroin's more sedation. And then diazepam, Valium, more of a sedation effect. This one says, you're on a psychiatry rotation and the attending turns to you and asks which medication or medications is known to decrease suicidality. Your answer choices are going to be lithium, Zoloft, Effexor, lithium and Clozaril, or Prozac only. There's two medications if you're in mental health and that decrease suicidality, lithium and Clozaril. Okay? But as you know, the step one exam, I wish they were that simple. I mean, you got to know that for the knowledge piece of it. But when you're going over the medications for step 1, you need to be able to take any one of these medications and run them through the ringer per se. If I said lithium, you need to be all over the fact that lithium is used for a bipolar mood disorder. Okay, on top of being reducing treatment resistant depression. Okay. And then it looks the same size as sodium. That's why it gets confused in the kidney sometimes. And then what labs should you do before giving someone lithium or monitoring throughout? You should monitor the thyroid, and you should order a complete probably just a BMP. You want to know kidney function. Okay, you want to know kidney function. And then what are the side effects? LMNOP, right? Side effects for lithium. Of course, this is lithium toxicity. It's the movement, right? So you got the tremors. You got nephrogenic diabetes insipidus. This O stands for hypothyroidism. Okay, that was on my step 1. Okay, it was this basic question. They gave all these different choices, and you had to know it was hypo. Of course, hyper was also an answer choice, but the answer was hypo. And then pregnancy, right? What's that condition? Epstein anomaly. So you gotta, obviously you want to make sure make sure they're not pregnant and stuff like that. SSRI, selective serotonin reuptake inhibitor. Effexor an SNRI, a little bit of norepinephrine in there too. Lithium we talked about. Clozaril, Clozaril is a good one. What lab should you? This is like treatment resistant schizophrenia. Okay? Treatment resistant schizophrenia. What lab should you do? Very, very, very important. You want to get a CBC. Why? Because you want to look at the absolute neutrophil count. Okay? That's a big time testable point there. Absolute neutrophil count with the CBC. That was on my test. Okay? It was on one of my tests. I forget if it was step 1, 2, or 3, but they're all fair game. Is someone starting on Clozaril, which of the following lab works should you make sure? And it was going to be a CBC because you need to know the absolute neutrophil count. And then, of course, side effects on something like that, you got to worry about constipation, people getting all plugged up, bowel obstruction with it, and then, endocarditis. When I say myocarditis with that. But for y'all's purposes for now, I just want you to know CBC, absolute neutrophil count, but know how to work every medication through this kind of back and forth, back and forth. They could say someone's got hypothyroidism, or their kid came out with this and they describe Epstein anomaly. Which of the following medications might they have taken, or their mom might have taken? And you need to go all the way back to lithium, or they might have said, what condition would she have had? And you better be jumping all over bipolar from the mom. All right, another one of those quote questions. 35-year-old woman comes to the physician for an initial visit. She refuses to fill out a questionnaire form about personal data in her medical history, then sits silently in the waiting room with her fist clenched. When the physician greets her in the examination room, she says, "Let's get this over with." Which of the following questions is most likely to facilitate communication with the patient? All right, so would you tell her, "Are you always such an angry person?" Probably not. "I can see that you're upset. Please tell me what's bothering you." Okay, maybe. "Okay, tell me what brings you in." If you do that, you're not even acknowledging that you can tell she's upset. I mean, she wants to know. She's sitting there with her fist clenched. You got to be able to pick up on those signals, right? "Should we reschedule your appointment when you're in a better mood?" At the end of the day, this might how you might feel, but it's not what you're going to say in front of your residency director, right? "Why are you angry with me?" Nope, you got to acknowledge that. She's angry at the staff. You don't have to be here if you don't want to. Again, you might feel that way at some point, but it's not what you're going to say. The correct answer is, "I can see that you're upset. Please tell me what's bothering you." Open up that line of communication, kind of acknowledge that you can tell that they're all not in a good mood. Now, this one says, which of the following is the most likely diagnosis? And you look through these, it looks like they're having some type of reaction. We got to know which one. Acute dystonic, lethal catatonia, malignant hyperthermia, NMS, neuromalignant syndrome, or serotonin syndrome. If it's this, there better be an SSRI on board somewhere. So it says, 28-year-old woman has a history of schizophrenia, is brought to the hospital by her friend. The patient has had multiple psychiatric admissions for the past several years. She has been maintained on haloperidol, which is Haldol, right? decanoate, which is a long-acting injectable shots. She feels strange after her last injection and is experiencing stiffness, cannot swallow, appears tremulous. She is concerned about an infection. On exam, her temperature is 101, it's elevated. Blood pressure is elevated. Pulse is elevated. Respirations are up. She has increased tone. Okay, I dictated these. Increased tone and extremities and appears tremulous, diaphoretic, and confused. White blood cell counts up. CK levels are up. What does this lady have? Now, if you look through these, acute dystonic reaction is kind of like I hate to say more like a muscle cramp. Okay, think of it like that. It's all of a sudden, it's sudden, and it can go away. Take a little Benadryl. It's sort of like torticollis. Lethal catatonia. Catatonia is kind of a spectrum of stuff, but it's like it's abnormal behavior. It's, you might have some immobility, you might have some strange movements. It's like this person who's just not interacting with their surroundings appropriately, and they don't understand why. But it says, when I look at this question, this person is worried about how they feel, all right? So the person who's catatonic doesn't quite, they don't understand where they're at. They're more confused. But this person's actually in tune saying, look, I don't feel right. So I'm a little bit less inclined on the catatonia. Malignant hyperthermia, well, with this one, this is usually secondary to, more of a medication, and she hasn't been taking any type of medication per se that's going to lead, kind of a, like an anesthesia med that's going to lead to this. That wasn't part of the question stem. Neuroleptic malignant syndrome, yeah, like NMS, right? If she's on an antipsychotic, Haldol, first generation, right? Haldol's first generation antipsychotic, very known for NMS. Step 1 loves that. I literally had a guy yesterday who, before sending him out the door, all of a sudden he was like, "Oh my God, my jaw's all locked up," and it's hard to tell if someone's malingering because they don't want to go to whether it's going back to jail or something. But you got to take it serious. So he was all locked up, real stiff, and he was on Haldol. So you have to be thinking that, okay? Or is it serotonin syndrome? Well, nowhere in here did we see an SSRI, okay? And there's not any type of anesthetic or anything that's going to give me the malignant hyperthermia. So this one's going to be the NMS, neuromalignant syndrome. And, with this, you're going to have muscle, again, all the stuff that we saw, muscle rigidity, tachycardia, we're going to have increased white blood cell count, we're going to have increased serum, and that's how we usually monitor it. We monitor serum CK levels. Or if someone's gotten a lot of Haldol because they're agitated in the ED, this is long-acting, but they have the short-acting version. If you get the Haldol in the emergency room, a lot of it, you want to check that CK level, okay? Yeah, 'cause that's sometimes elevated. But anyways, in this situation, all signs point to NMS. It's a good question. Good question for definitely for step 1. Okay. This one says, 39-year-old woman with rapid cycling bipolar is treated with valproic acid, also known as Depakote, right? 1 month after she starts taking a second drug, her valproic acid concentration is decreased by 20%. So things went down by 20%. Something kind of induced the metabolism of the valproic acid. So which of the following is most likely second drug? So this just goes back to, remember what we talked about. You better know your inducers and your inhibitors, right? And you better just flat out stop the video, memorize these things, put them on flashcards until you get them right, okay? And that's that whole, again, queen barb, even though I think the quinidine, not very common, also transition to the other group. Anyways, long story short. Cream barb steals fen and eats greasy carbs continuously, and then the inhibitors are going to be your magic racks. Now you don't need me to go through those and bore you, but you better pull out your step 1 book and you better have those things memorized cold, okay? If I came across you on the street and stopped you and said, "Hey, give me all the inducers and inhibitors, give me the common ones," you should be able to regurgitate these things back to me very quickly. So I'm looking for an inducer. Out of all these, you're looking at carbamazepine, okay? Benzodiazepine, this is antipsychotic, neuroleptic. First generation, here's a second generation, Risperdal, and then of course grapefruit juice is going to be on your inhibitors, okay? The only one that's going to decrease it is going to be this one. Now, they could easily have changed this and said which one increased it by 20%, and then you might jump on grapefruit because it's more of an inhibitor, okay? you better know how to go back and forth on these, hands down. Okay, which of the following physiological effects is most likely to be observed? And it says an 18-year-old male is brought to the emergency department by his mom because of strange, inappropriate behavior. The mother says he laughs a lot and seems overactive. He's 18 now, so it's not like he's 5 or 6. When asked in private, the boy admits smoking marijuana. Which of the following physiological effects is most likely to be observed in the patient? All right, so as you know, I would take the extra step and learn all about the marijuana, because the people who are writing these exams know that it's becoming more and more and more common out there, right? All the states are legalizing it. So I would just know it, okay? Know it. But in this situation, what's the sign and symptoms of marijuana use? It's going to be conjunctival injection. Yeah, okay. Pretty straightforward. If I was to, meiosis, pinpoint pupils, I always think like this. If it's an opioid intoxication, I say opioids like an O, so it's pinpoint. If it's cocaine, my eyes, and my overdose, my eyes are going to be bigger, right? Cocaine, big C. And then pinpoint pupils is going to be the opioid. Alrighty. And let's go to the next one. It says 79-year-old man who lives in a nursing home has a fever, muscle rigidity after receiving a drug for the treatment of a psychotic episode. Fever, muscle rigidity. Sounds very familiar, right? Which of the following drugs is most likely to cause the adverse effects? So what does this guy look like he has? He's leaning toward MS, right? And he just got a drug for a psychotic, right? Psychotic, delusions, hallucinations, disorganized thinking. And so I'm looking for a first generation antipsychotic. What is the most common one out there? They're going to use using the Haldol. Very effective medication. I love using it because it gets behaviors under control quick, but I got to watch out for this kind of stuff. You can still use it even in old people, but it's more of a temporary use. Now again, clozapine, what kind of lab am I going to order on this? I'm going to order a CBC. Why? Because I'm going to measure the absolute neutrophil count. What are my side effects that I have with this thing? Constipation, myocarditis, and then what's another side effect? Hypersalivation. A lot of times people kind of drool when they're on this medication, so you kind of give them that atropine to use in the mouth and spit it out. Because if people regurgitate the hypersalivation, then they can get like an aspiration pneumonia. We see that a lot with clozapine per se. Valium, diazepam, Valium, it's benzos, and it's not going to cause that. Risperidone, it's second generation. It's just not as known to cause these type of symptoms. You got to be leaning toward the Haldols of the world. Lithium, again, what labs would I do? I would do a TSH and something to check the kidneys, whether it's a BMP or maybe it's in a comp. And then it treats what? Bipolar and treatment-resistant depression. And my side effects, LMNOP, right? Movement, which is tremor, nephrogenic diabetes insipidus, hypothyroidism, and pregnancy, right? The nephrogenic diabetes insipidus. Olanzapine, also known as Zyprexa, it's also a second generation, and this was known for, really the side effect is going to be the weight gain, okay? It's going to be the weight gain. This one says, 18-year-old girl develops torticollis, diffuse muscle rigidity, okay, 3 hours after starting a new drug for a psychiatric disorder. The most likely cause of these findings is antagonism or inhibition of which of the following receptors. Again, psychiatric disorders, even if you don't know, you need to always jump on dopamine, okay? Dopaminergic. Give her some, obviously you want to give her some Benadryl, some Cogentin, get this under control before it gets out of hand. Now be careful on the step exams because they're going to throw some distractors of D1, D3. You got to know it's D2, okay? Know it. Thank me later if you come across that question. This one says, 70-year-old man has been taking dopamine agonists for 5 weeks for Parkinson's disease. He's had some benefit from his treatment and decides to increase his dose. Which of the following adverse effects is most likely to result in the increased dosage? Now, remember, Parkinson's is kind of like, hey, you're a little bit lacking in the dopamine, so we're going to give you some dopamine. But if we have too much dopamine, right? If we have too much because, this guy decided to increase his dose on his own, think of it like this. We give Haldol, which is a dopamine blocker, to control psychosis, right? It reduces psychosis. So if I'm doing the opposite, if I'm actually giving this person, or they're giving themselves, I'm sorry, too much dopamine, it's going to cause psychosis. Okay? Got to know that. And then, you know, if you're looking at side effects like acute dystonia, that's going to be our, you know, again, like more of a muscle cramp. If they say akathisia, that's going to be the restlessness, right? That's the guy kind of rocking back and forth in the chair. Restlessness, akathisia, AK, okay? Restlessness. And then if you see the word tardive dyskinesia, that's the one where it's like the mouth, right? Their mouth keeps, like they're licking their lips or puckering their lips constantly, and you get that kind of like that lip smacking sound. That's tardive, okay? Stop the medication, all that kind of stuff. All right? Kind of know those side effects. This one says, what substance does he abuse? 38-year-old man presents to the emergency room complaining of a one-day abdominal pain and diarrhea. He refuses to answer any questions about his medical or social history and appears very agitated. Physical exam reveals tachycardia, rhinorrhea, and dilated pupils. You suspect the patient has been abusing a substance and is experiencing withdrawal. Okay, what substance does he abuse? So whenever you see like abdominal pain, diarrhea, you know, on the withdrawal end of things, you usually don't get too much on these. A lot of these guys might be a little bit, discomforting, but the one that's going to cause this abdominal pain and diarrhea that you have to know, it's going to be the opioid. In that situation, it's going to be the heroin, okay? One of the big things I want you to know for step one, this is very, very kind of common, is you got to know the alcohol. You got to worry about the guy they usually put in a question sent the guy's homeless. And he's going to come in for some procedure, right? He comes in for some procedure that he needs. Maybe it was cold outside, but then when he's there, he gets treated for pneumonia. Now, several days into this, you know, between 3 to 5 or even up to 7 days into this, all of a sudden he starts acting bonkers. You know, he starts acting weird on the unit. What's going on? You got to be thinking, and yes, it is stereotypic, but they're wondering if you know to make that kind of, if the guy's homeless, is there a likelihood that he drinks? Perhaps more than someone who's not. But they want you to make that connection that you have to kind of dig deep, that he could be acting this way because he's going through perhaps alcohol withdrawal, and that's going to be your delirium tremens. But be aware, there's some questions that I've seen out there that all you get is some guy who came off the street, comes in for procedure, and then he starts acting, you know, crazy within a couple days, and they're saying, well, was it because of the procedure? Was it because of the medication he received? No, it's because he's withdrawing from alcohol, okay? So for this answer, it's going to be heroin, but don't forget to review what alcohol looks like, okay? So I hope these were helpful, and we'll see you in the next video.